what are the surgical tenets, which are the main principles. The first one is, you remember I told you some that you can go very easy or you can go very complex in your surgical technique. The easier approaches are more safe, but they're less effective. You remember the paradigm of the syrinx. 65% syringomelia shrinking when you remove the bone versus the 85 and 90% if you do a duroplasty and you shrink the tonsils. The argument is so strong that the people who are the proponents of the craniectomy alone, they define as success when the syrinx does not grow any further, which is not something that the majority of the pros in the field accept. We define success in syringomelia management when the syrinx shrinks, not when it stays unchanged. So, easier approach means more safe but less effective, means also the opposite. More complex approaches are more risky, but they're way more effective. So at that point, I already gave you the syringomelia benchmark, the example. What do you choose? What do you choose? There is no ideal solution, okay, for everybody, and probably will never be. Because, like, the patients are different, the surgeons are different. You cannot force to somebody who's more experienced, whatever, a more simple procedure, knowing that if he's going to do the extra steps 1, 2, or 3, he's going to get a better population of patients. On the other hand, if the surgeon is not comfortable about going beyond this technical comfort zone, it would be absurd to say, okay, the standard of care for neurosurgery is this, including the tonsillar resection. It took me 18 years to come to do the tonsillar resection day in, day out without having problems. And I did not rush into it. If somebody like with a limited experience cuts in that, the next thing you're going to have is going to have a series of patients with brainstem strokes. What are the recent trends? Extradural techniques, cutting the bone alone. Some advantages in very young children, because in very young children the dura is so thin, unless you are at the top of the game for Chiari, it becomes very difficult to do a duroplasty without a pseudomeningocele, without a CSF leakage. Minimally invasive approaches, which means you make a small incision, you go in and you do things. And some people also try to do minimally invasive through ports. Ports are very small tubes, hollow tubes you put in through which you do the surgery, kind of a minimally endoscopic. Then there is the MIST. The MIST is called minimally invasive subpial tonsillectomy and was first born in China. We're first born in China at the Institute, the Department of Syringomelia. I first met Dr. Liu in 2007 in Rugby. We were at the international meeting. Dr. Mirat was the keynote speaker for the meeting. And here this guy with his broken English comes to us and he says, I want to meet you, like a big admirer of your center, your institute. I built something similar in Beijing and I just want you to hear about me. And he was in the minor paper section. So I go in and all of a sudden he starts presenting the first slide and I discovered that out of the blue, this guy was having this number 2 institute in the world for number of patients seen and number of surgeries done. And out of the number of patients he was having, again, Chiari patients are mostly Caucasians or Asians because of the size of the skull, which is different from race to race. In Asian people, they have a flat head, therefore they're more prone to develop Chiari malformation. He had 2 billion Chinese to play with. So all of a sudden he had a limited amount of surgical time, so he had the problem of how can I do the surgery faster? So he started developing this technique called MIST, which is minimally invasive, small cut instead of the usual big cut, subpial tonsillectomy, which is what everybody was already doing. Then we met, we compared notes in the aftermath of Dr. Mirat's retirement, and we came out with 2 techniques, the MIST A, which is the Beijing type, and the MIST B, which is the New York type. I show you the New York type, which is a 2-inch incision, at the base of the skull, and we remove a very small amount of skull. So first we drill it, we expose the dura, we do not open the first vertebra, we check with the ultrasound we are on it, and we do just a very small 2 centimeter long incision, through which we bipolar coagulate the part of the tonsil we can reach, but the inside of the tonsil stays medium rare. So we slice them open, we repeat the same process inside, then we suck and cut the dead tissue out. That implies that we buy so much space inside that we don't need the duroplasty anymore. We don't need to make a big hole in the skull, because now the brainstem is decompressed, the 11th cranial nerve and the vertebral artery are decompressed, and the equalizing hole of the foramen magendi is wide open. So what do? We just close the dura directly. Before, after, this all bought space. Everything is decompressed, everything is fine. We do not need the duroplasty, and the advantage, that closure we do is in the thickest part of the dura. How convenient. So far I did 292 of these cases, I had 0 leaks. So, okay, you can be lucky up to a certain point, but luck can carry you up to a certain point, then the advantage of your technique comes out. Sooner or later I'm going to have the leakage out of this, whatever. But what this means? It means that it's much easier to repair the dura when you're dealing with the thickest part of the dura. When you're dealing with the parts of the dura which are on the butt cheeks of the cerebellum, because they look like that, the dura over there in Chiari malformation patients is at the thinnest. Sometimes it's so thin that it's ridiculously thin to the point you can see through, and when you put stitches, needles through it, it's like trying to repair wet toilet paper. It becomes bad. That's why there is such a high incidence of cerebrospinal fluid leakages. On the other hand, repetition can get you better. With Dr. Mirat and I, over several years we were together, we were having a 0.3% incidence of leakages. Were we better than the others? No. It just comes like tying your shoes. You get better just by repetition. So everybody who now is 4%, check again on them, 5 years from now, they're going to have something below 1. Now, the complex Chiari, we already said it before, is an important approach because you have 2 problems. You have the Chiari malformation coexisting with a problem with craniocervical instability or abnormal anatomy of the craniocervical junction, the junction between the neck and the skull. So how do we tackle it? We do the posterior fossa decompression and a craniocervical fusion. And sometimes, in some rare cases, you also have to add a third procedure, which is the transoral odontoidectomy, which is when the odontoid is, despite all our best efforts, you immobilize it, but is still exerting a pressure against the brainstem. Now, main problem here is how do you deal with it? This is the Cadillac of craniocervical fusions. Back of the skull, back of the spine, you put screws in the spine, screws in the skull, 1 bar on the right, 1 bar on the left, and that blocks the joint. Blocking the joint is good because the movement of the joint is what gets you in trouble, but you have some problems. Now, this is exactly the place where we would do the Chiari surgery. So all of a sudden you have a conflict between, all right, I have to remove bone, but then in the same place where I remove the bone, I would like to put screws in it. And it's not polite for me to put screws in the brain because it doesn't take so well. Another thing is that in order for the surgery to be effective and to immobilize this joint, you have to go above and below, and you have to insert a contoured piece of hardware which follows the bone. So it's not that the bone is here and you put something like this, because then you cannot close the skin. So you have to adapt it on the bone surface. But that makes you for a very long and clunky piece of hardware, which can be 4 to 5 inches in length. The problem is that the hardware alone, even the best of titanium with cobalt, chrome, whatever, is not enough. So you have to have that reinforced with bone. If you go in a major building, what you're going to find? Pillars made of armored cement. There is metal and there is cement. If the metal were by itself, the metal would bend over stress over time. If you put just the cement would crumble over time. You put them together, they're better than the sum of the two of them individually. So what we want to do is to achieve this kind of result in which bone reinforces the hardware. Now, unfortunately, you also have problems with bone metabolism. So especially the patients with connective tissue disorder have lousy bone metabolism. Vitamin D should be triple digit, is single digit in many of you guys. All the kind of enzymes which build the bone, they're defective. And guess what? The bone is connective tissue, so you go with that. Put also together, this picture you have here with the good solid bone reinforcing is the exception around the rule. And more often than not, you find some bone here, minimal bone here, and a bar being naked over there, exposed to the risk of thing. Plus, another problem you have with this is that this contour of this become very annoying underneath the skin because there is not a lot of flesh on it. So to the point that with this construct, the distress of the patient from the contour is not even considered a complication anymore. It's considered a given. And the only difference between the guys who are suicidal about it and the guys who are saying, yeah, it bothers me a little bit, but it's not that bad. So the technical dilemma when you have this complex Chiari scenario, when you have two surgeries to do, is you do it together the same day, or first you do one and then you do the other one later. It depends the stage, first one and then the other 3 months later was the rule. Right now, the trend is to do it combined at the same time. The main technical problem is that the posterior fossa decompression and the craniocervical fusion compete for the same piece of real estate. Skull over here. The Chiari surgery wants to take it out. The fusion surgery, please leave it in as much as you can because I want to put the screws there. Because as soon as you go on the butt cheek region of the cerebellum does like this from the inside and makes the skull so thin that in some patients I can open the skull over the butt cheek of the cerebellum just with my nail. So you don't even need the drill, so thin it is. Obviously, it's to something which is sub-millimeter. How can I put the screw which is 10 millimeter long? So the point is that the posterior fossa decompression, the Chiari surgery wants to remove bone. The craniocervical fusion not only wants to keep it, but also wants to add something on top to reinforce the bars. The craniocervical fusion needs for the screws to take thick bone that you guys do not have to begin with, and if we remove it, it's also going to restrict our choices. So somebody would say, oh yeah, why don't you go more wide? If you go more wide, you're going to reach the mastoids, which are full of snot, and you don't want to put screws there because otherwise you're going to have an infection. The posterior fossa decompression, so at that point you have a dilemma. Who do I shortchange, one or the other? Do I do a perfect decompression and a lousy fusion, or vice versa? So after having agonized on this for a number of years, after the Chinese Revolution, I had one piece of the thing, and after 2009, I had another issue, which was that one of the mini craniocervical fusion. The mini craniocervical fusion is based on, okay, I have to put screws in the skull, screws in the spine, I put screws in the back of the skull. No, I don't give a damn about the back of the skull. I go in the base of the skull. All right, so how do we get there? First, again, picture from before, we have a scenario like this, combination of big problem of the craniocervical junction and big problem of Chiari. I had to do both combined. Enter the condyle. The condyle is this structure over here, these two wide commas, which are exactly around the foramen magnum, which is the hole through which the tonsils are coming through. They are in the middle of the action, and they have nothing to do with the part of the skull which gets removed at the time of the surgery. So this is here, this is the part of the Chiari surgery. They're neighbors, but they're not affecting each other. So you're already understanding that doing one surgery is not going to compromise the other one. All right, so what are the condyles? The condyles are the two big bone pillars, thick bone, which is what we want, on which the entire skull is resting on the way to the spine. This structure is very thick, and it also has a hole, sort of a tunnel, through which there is a nerve which is going to the tongue, which is called the hypoglossal nerve. So if I do like this, it's because I'm using the hypoglossal on one side and the other side. To give you an idea where the condyles are in space, this is the occipital bone, which is the base of the skull and the back of the skull, solid in one. And this pink thing here are the condyles. And to give you another different perspective, the condyles, we're here marked with the letter B, and this is the foramen magnum with the letter C, and the letter A is the first vertebra. So you see that the condyle is the gateway of the skull, or the pillar on which the skull is resting on top of the spine. So it's a very good position. So you say, all right, why don't we get there? Okay, it's so thick. If we drill through it, it's a big, thick thing. You can put a big, thick screw. And this skull here is in a normal person, not in you mutants, in which this skull here becomes very thin. So you have one of the thickest parts of the skull. Why don't you go there more often? The problem is to get there. First, there is some neighbor which is a little bit demanding, which is the vertebral artery, which is passing nearby. The second thing is that there are a lot of other veins and structures in the side. So this entire area here is covered with veins. So going there is a little bit more time consuming. We were talking about, among the experts, we were wondering, who's going to be the first describing it and doing it on cadaver first and then on a patient. The first guy doing it was Dr. Uribe in Florida. Again, he's a neurosurgeon. And he first described in 2009. It was in 2010, as expected. First neurosurgeon started doing it on the first patient with Chiari malformation who had a massive decompression. The issue is, if you have a patient, he's missing the entire back of the skull. At that point, and needs a craniocervical fusion, you are in a desperate situation. At that point, you are forced to go to the condyles. So the condylar screws up to 2010, they were considered a rescue procedure. Whenever craniocervical fusion needs to be done, but you cannot put any screws in the back of the skull. A rescue procedure means, gee, we're really painting in the corner, we're really, really in a bad situation, and this is the only way out. So damn the torpedoes, I'm going to do it because otherwise the patient is going to be really in a bad predicament. The screws you can put in are enormous. They're 2 centimeters long, the part of the screws which are inside the bone, and they're very thick. So instead of multiple puny screws that you put here to try to keep it attached to the skull, instead of 8 screws, 4 per side, you're just 2 screws, 1 per side, in the base of the skull. So this is the combo of Chiari and Chiari surgery. This is the missed procedure, very small amount of bone removed, a small linear incision reinforced. First vertebra is still intact, so this entire thing is done through a fraction of the bone removal of a classical Chiari surgery. These 2 screws are in the second vertebra, these in the first vertebra, and these 2 are in the base of the skull. So we pull the head up, we drop 2 bars, one on the right, one on the left, and it is done. You have a cranio-cervical fusion. And you remember all that clunky, long, bent hardware you had before? You only have this. Instead of 4 to 5 inches of stuff, you have 1.25 inches worth of straight bars, much thicker than normal, which are more difficult to be bent and much easier for the bone to reinforce it. So instead of 4 inches for the bone to cover, now you're going to have 1.25 inches. This is the joint between the skull, the first and the second vertebra, and this is the epicenter of the movement, which is exactly where you're going to put the 3 screws. So from a standpoint of biomechanics, which is a big word that is so trendy these days, is you put exactly the screws where the problem is. And you put the longest possible screws you can put, and they all have the same orientation in space, and they're close to each other. You can get better than that. And this is the bone fusion you can get. Instead of the rinky-dinky little trickle of bone you can find in most of the patients, you have a solid chunk of bone over here, directly underneath the bars on top of the bone. And this is the kind of thing you see in a more sexy representation. So you see the posterior fossa decompression and the hardware. Now, as per the posterior fossa decompression alone for Chiari simple, the management of complex Chiari does not have a standard of care. The only agreement is you need 2 surgeries, sometimes 3 when you need the odontoidectomy. 1 when you need the odontoidectomy. You need an odontectomy when, even after your best efforts, the odonto is stuck in that position against the brainstem. So the only way to do it, to get it out of the way after you fuse it, at least it doesn't bang anymore like this, is to go through the mouth and to incise the back of the throat, to go in with a big drill and to drill it off. Up to the point is you stop before you hit the brainstem, but you drill it off and you remove the compression. So again, there is no standard of care about how the surgery should be done. The only agreement about complex Chiari, which is the hottest topic now during the course of the last 2 years among Chiari experts, is that you should do a Chiari decompression, a craniocervical fusion when indicated, and you should do it preferably in a combined procedure so the patient gets in, gets out, and it gets done. All right, so I'm going to stress again one more time. There is no single technique which is absolutely better than the other ones, because a technique which is more effective, like for example the mist technique, is also more difficult to execute, therefore can be more prone to risks. So it becomes a choice of the surgeon and a choice of the patient, because we are together in as a team. So you cannot force a surgeon who, not afraid, but is concerned or he feels uncomfortable about going outside his boundaries of comfort. You cannot, you as a patient say, no, yeah, Dr. So-and-so does it, so I want you to do it. The guy is better doing the things he's comfortable with. And comfortable means also experience with, and he knows the ins and outs, and also how to scratch the complication if that happens. On the other end, the patient also has choices. The way I tell the patients when they come to me is, I'm like a Chinese restaurant. I can tell you what's the surgery that I prefer, that is my sentimental favorite, which are the mist for Chiari and this combination for Chiari Plus, Chiari Complex Chiari, because this has given me the best chunk of happier patients. You get a patient who's happy, and a patient who's happier, a patient who has some residual headaches, and a patient who has far less residual headaches, and far more symptoms which are nearly extinguished. So it's a promise of shades of gray. But again, it's a patient's choice as well. If the patient feels uncomfortable about having a piece of the brain being chopped off and is very attached to it, or on the other end, he feels uncomfortable with the idea of doing an aggressive operation because he's not by nature a risk taker, or on the other end, had a bad dream and he says, no, I don't want to do this surgery, I want to do another one which is safer. That's patient's choice. Again, the doctor and the patient are in it together. So these are all spectrum of options, and some doctors can be able to go from one to the other and one end of the spectrum to the others. Some others are going to be limited by their experience just to one part of the spectrum. Other doctors are going to be limited by their own convictions to just staying in one part of the spectrum, not because they couldn't do more, but because they're really convinced, pending definitive data, that that's the way to go. But again, it's a decision we take together. There's still a lot of things that we're going to know better, and we're going to know more about Chiari malformation during the course of the next decade. It's going to be very interesting to be in it together, because like everything in life, the more numbers, the more evidence, the more people discussing, the more we're going to go ahead together.